Okay, so we're going to talk about rural health and migrant health. So compare and contrast definitions for rural and urban, describe the health status of rural populations, discuss access to service issues of rural undeserved populations, define migrant farm workers, and explain the nursing role for serving persons in this area. All right, so access to healthcare. Rural populations is hard. Think about people who don't live near a level 3 NICU. They have babies in a community critical access hospital. Something goes wrong, that baby has to be air flighted. When there's a scarcity of health professionals, there tends to be poverty, limited to access to service, lack of knowledge, and social isolation. When you live in a city or you live near good hospitals, it's really hard to imagine that, but it is happening. And then you have to think about migrant workers or those who are undocumented. You can't just use the word migrant worker. And caring for their health. And it is important because they're still a very big part of this economy. So rural is more farm residency, urban is non-farm residency. Moving to rural areas, it's the fastest growing area the donut effect, and there's more affordable housing, and then it pushes people out further and further. So population characteristics and cultural considerations for rural populations. There's a higher proportion of whites, what they would call poor whites, higher than average numbers of younger and older residents, so big split, more likely to be married or widowed, few years of formal education, they tend to be poor, and higher risk of being underinsured or uninsured, especially in farming communities. Health status of rural residents, so poor perception of overall health and functional status, less likely to engage in preventative behavior, more likely to have one or more of the following chronic illnesses: heart disease, COPD, hypertension, arthritis, rheumatism, which is just basically another word for arthritis, diabetes, cardiovascular disease, cancer. They have poor health and less likely to seek medical care, and traveling time or distance to ambulatory care services will affect their access to care. So health providers live and practice in particular communities for decades. They may provide care to people who live in several counties and small staff to service a large area. So for a while, we were living in a rural area, and I was a nurse practitioner in a very rural area, and people would drive from all over to be seen. And it was a critical access area, and there wasn't many of us, and there was a lot of people who came from hundreds of miles away. And there's health professional shortage areas, especially in reservations. That's a big area. So women's health, including maternal and infant health, there's higher infant and maternal morbidity rates, high proportion of racial minorities and fewer specialists, extreme variations in pregnancy outcomes. We don't have good prenatal care. It is linked to poor pregnancy outcomes. Particularly women who live near or on an Indian reservation, you're a migrant worker, African American descent, and live in a rural county such as the Deep South, or victims of sexual assault. Yeah. Alright, so health of children. Urban children more likely to see a pediatrician when they're ill. Rural adults and children more likely to have a general practitioner as a regular caregiver. Children who work on farms are less likely to attend school, have health literacy, and then school nurses are people who do a lot of the screening and findings of things. So you think of your school health nurse here, you're just kind of like what a limited role they have, but in rural areas, they are the first person that catches health issues. So mental health, there's delay in seeking care, there's really no access. I mean, think about how there's poor access in general. There's a high rate of poverty that causes depression, geographic isolation, and insufficient number of mental health services. Concerns with domestic violence, there's a high rate in rural areas, alcohol, tobacco, and other drug use, especially heroin and methamphetamine. Methamphetamine was a big one for rural areas. It kind of used to be that joke, like, okay, you have nothing to do here but tip cows and do meth. That's a big problem in rural areas, and there's just not enough care for that. So, occupational environmental problems. I want to skip down to pesticide exposure because that's just a huge problem, and it causes severe lung issues over time. So that's just something to talk about. I get lots of people who've lived in rural all their life and have this terrible asthma, and you just kind of wonder what other things is going on inside them because they've been exposed to these chemicals. And of course, common injuries. There's lack of OSHA regulation on farming, especially for migrant workers. There's no one there overseeing how long they work and in what kind of conditions. And there's high risk. When you think about people who mine, who fish, who forestry, agriculture, there's risk for disease and injury. So rural healthcare delivery issues and barriers to care. So barriers of, access, availability, affordability, and then acceptable services and professionals. When I first started as an MP, I went and worked in rural healthcare. Why? Because that was where I could get hired. So was I a good enough, provider? I hope so, but probably not as good as someone who had 20 years experience. Someone who has 20 years experience, unless they're really passionate, they're not going to live rurally and get paid less. They're going to live somewhere where they get paid more and it's more comfortable. I mean, technically, that's what they say. That's not necessarily true. There's provider attitudes, insights, and knowledge. Not understanding the farming community. I don't know anything about that. When I work with migrant workers, I didn't understand any of their lifestyle and risks that they're exposed to, so it was hard to talk about prevention until I did. And then designing community health programs that fit the rural lifestyle. So health of minorities, particularly migrant farm workers. Characteristics of migrant farm workers. So migrant lifestyle. So migrant farm workers is migrant, right? They're transient. They're moving from place to place. Trying to teach about having medical records on them, having their shot records on them. What's their lifestyle? Living in crowded housing. Maybe not getting regular checkups. Long days at work. Not very healthy food. Their housing. You need to think about what is the issue with their housing and then issues in migrant health. There are migrant health centers which are really helpful, but there's not enough. So issues in migrant health, lack of knowledge of services. People are scared. They're really scared to go and seek care. Inability to afford care, availability of services, transportation. Hours of service. If you're working from sun up to sundown, you're not going to go to a regular 8 to 5 office. Mobility and tracking, like I said, they're transient. So if you don't keep your shot record on you, how do you know what shots they need? Language barriers is a big part. So I speak Spanish fluently, and that's helpful. And I can tell you, now I have more Nepali patients, and my visits are so much more frustrating that I don't speak the language. I can't even imagine what it's like for them. Discrimination. People really discriminate against migrant workers. It's a hot button topic right now. Documentation, cultural aspects. So, in the way that there's treatment, people, especially when it comes to mental health. Children of migrant workers, if they don't go to school. Dental disease, that's a big one. In developing nations, dentistry is a luxury, and it's only taken care of when there's a major problem. Incidence of TB, HIV, and AIDS. Screening for that, we got to screen for that. Depression, anxiety-related disorders, domestic violence, and children. We talk about children, migrant workers. Domestic violence is a big issue. We see that a lot with our undocumented patients. And then anxiety. I mean, imagine how isolated it would be to live or not be able to understand the language and not know where they are from time to time and what's available to them and what's going on with them. So cultural considerations in migrant health. Oops. All right, so the nurse-client relationship, health values, beliefs, and practices. So I know it's hard. I know regardless of what your political beliefs are or whatever, migrant healthcare is something that's been going on for decades. The nurse-client relationship might be the nurse-client family relationship, might be the mother-child relationship. Making sure that the relationship is comfortable and respectable, but also knowing when it needs to just be nurse-client. Health values, beliefs, and practices. That's really important to consider and to respect, especially if there's no harm. But understanding, just like the cultural differences. And we used to have that little book, and it used to say, like, Latino people like to eat warm things after they give birth. And I'm Cuban. This always made me laugh. Cubans give their babies meat a lot earlier. Some cultures don't encourage breastfeeding, and so there's a line in respecting and educating with that. The whole thing with cupping with some of the Asian cultures, and just trying to be respectful of that. So community-oriented nursing needs to vary by community. So there's prevailing need in most rural areas, especially for the following. There's school nurses, which is really important. School nurses catch a lot, especially in rural areas, especially when you don't go to a doctor on a regular basis. Kid keeps coming in with stomach pain. Is it anxiety? Are they getting bullied? Do they have something wrong with their stomach? Student keeps peeing all the time. Are they diabetic? A student keeps, getting short of breath. Do they have asthma? I mean, literally, there are people who walk around with asthma for years and don't know it. Family planning services. Okay, what about birth control? What about prenatal care? What about prepping a woman for a healthy pregnancy? Caring for an individual with AIDS in their family. AIDS is an epidemic, and it's not just has to do with homosexuality or sex. It can do with needle exchange. And if you have HIV/AIDS and you're in a rural area, it's hard to get the care. Emergency care services. You have a level 1 trauma center around, you get a really bad accident. That's a problem. So you have to address that. How do we address that? Do we have a critical access to another hospital? Mental health services, and then services for the adult. So case management, community health, and primary care. You define and characterize the community, identify the community's health problems, develop and modify healthcare services in response to the community's identified needs, and monitor and evaluate program process and client outcomes. So what are the needs out there for this rural community, and how can we improve on those needs? How do we develop or modify the healthcare services that we have? Okay, so we don't have HIV/AIDS clinic. How do we get access to infectious disease? Can they train our current providers in infectious disease? There's no hard, fast rule that AIDS has to be treated by an AIDS specialist. So let's get the providers that we have out there ready to do that. Mental health. Mental health can be treated by a generalist. They just have to be specially trained. So Healthy People 2020, many objectives relevant to rural migrant populations. And then implementing the objectives, consider rural factors. So community has to be involved so they can assume ownership so that you're not just keeping it there. And then consider how to use the resources that they have. So we talk about informatics, text messaging, telehealth, telephone, video conferencing. And that goes both ways with healthcare providers.